Lovely, thank you. So I feel a slight fraud because we don't use PET for planning. So I will show you bits and pieces about PET for planning, but we don't actually use it in Leeds at the moment. We've been involved in various research projects and things, so we've got a little bit of experience, but we haven't actually treated patients with it. So this kind of talks a general overview of what PET might be used for in terms of radiotherapy planning and perhaps where the future might go, because this is an area that I'm sure is going to change pretty quickly. So as you know, modern radiotherapy is very highly conformal. We've got very steep dose gradients now in many of the treatments with IMR3 treatments, stereotactic treatments. And that leads to the potential for marginal misses. So in a sort of previous era where we treated people with, perhaps in the head and neck area, with lateral opposed pairs and big blocks, there wasn't much potential for a marginal or just edge of field miss. But now we've got very steep dose gradients. We do see the potential for marginal misses. And it makes a big difference, the quality of the radiotherapy. This was a study from a few years ago, and they did a retrospective analysis in terms of whether people followed the protocol. It's a head and neck study. The study was actually negative. It was looking at radiosensitizer, and it came out as a negative study. But if you looked at the patients who had their protocol followed, they had a 70% survival, and patients who the radiotherapy protocol was not followed had a 50% survival. So it was a very big difference. It makes a very big difference about the quality of the radiotherapy. And one of the big things in that was about the target delineation. And remembering that's in enthusiastic centres who've opened big trials. So these are the good centres participating in this study. So even in good centres, the target delineation and the quality of the radiotherapy makes a very big difference to patient outcome. I think probably one of the main factors in that is target delineation. So this was a study from a few years ago. This was in larynx hyperpharynx patients. And they got a group of experienced radiologists and radiation oncologists, who was in America, to contour these supraglottic tumours. And this is a figure from the paper, but you can see there's one contour in red and one contour in white, and they're very different. And there was only about a 50% concordance between these contours in the whole series they did. So basically there was huge inter-observed variability in people trying to contour exactly the same tumour. So this is a quote from a review a few years ago, but it's basically saying tumour delineation is the weakest link in the search for accuracy in radiotherapy. So all the actual radiotherapy delivery will have very tiny, systematic and random errors of the order of the millimetre or maybe slightly more. But in terms of actual tumour delineation, when we, as an oncologist, contour the tumour, we're aware there's significant variation of more than that in what we do. So this was an example in lung cancer. This is a lung mass. And again, a group of experienced lung oncologists were asked to contour this tumour. And they came up with hugely varying answers. Now, if you're then delivering highly conformal radiotherapy with steep dose gradients around that, you can imagine it makes a pretty big difference where you've drawn the tumour. And it's a bit perturbing to find such different tumour contours. So we could easily miss, essentially, or overtreat. If we're drawing something too big, we're going to treat much bigger volumes than we mean to or need to and get excessive toxicity. So the question is, can you use any other sort of imaging? A lot of this is related to a clinician on a planning CT trying to work out where the tumour is. And clearly, we're not going to be particularly good. If you look at that picture, some of those people are probably right, some of them are probably miles wrong. So can we use any other imaging modalities to improve our ability to define where the tumour is? And there's a great deal of interest in functional imaging. So functional imaging is looking at some of the sort of biological processes within the tumour. So this is with a PET scan. So as you can see, suddenly everyone's drawing pretty much the same thing when they're using the PET CT scan to draw the tumour. That doesn't necessarily mean it's better. Everyone's drawn the same thing. They may all be drawing the right thing, or they may now all be drawing the wrong thing. And that's where the sort of questions of how you might use PET come up. So PET's a very big development, and it's a relatively new field. This is Time magazine in 2000, and it was the medical invention of the year in 2000. And we had the first clinical PET scanners in 2001. So this is that's only sort of 14 years ago. So it's a very rapidly developing area. There's been huge advances even over that time. So it's a technology people are really still very much learning how to use. And there are lots of questions. It's a very active research area. And certainly the first sort of, I don't know, 8 years or so of this process, they were just standalone PET scanners rather than combined PET-CT scanners. So even the sort of, when you look at the data on PET, the early days are probably not very relevant to now because the scanners were very different to what we have now. But now we have an integrated PET and a CT. So what a PET scanner does, essentially with a PET scanner, you're giving a radioactive emitter attached to some sort of biological molecule. And so the emitter is going to go with the biological molecule and show where that's taken up. In terms of detecting it, it emits a positron, which travels a very short distance of 1 millimetre or so, which then annihilates when it meets an electron and then releases gamma rays, essentially, in perpendicular directions. And the scanner can sort of computer reconstruct where that emission is from. So that's the basis of what a PET scanner is. By far the most commonly used tracer is fluorodeoxyglucose. So it's essentially glucose, so it's sugar. So it's going to wherever a tissue is using sugar. So if you give fluorodeoxyglucose to somebody, it's given as an injection. So when the patient comes for a PET scan, they are cannulated. They then actually lie flat they're injected and then they lie still in a room for about an hour just to allow this sugar to be taken up into the tissues. And they have to lie completely still. They can't do anything. They can't read books or move around because as soon as you move, the muscle is active and takes up the sugar. So they have to keep completely still, and it goes to any tissues in the body which use sugar. And the uptake's based on multiple things. Broadly, it's going to show you areas which are metabolizing glucose. But it's also going to relate to perfusion. So obviously to get there, you're going to have to have blood perfusion. It's going to relate to glucose transporters on the cell membrane surface and then aerobic glycolysis within the cell. So it's a kind of multifactorial process whether things take up glucose or not. And then after that hour, they then can go on the scanner. And the scan takes about 30 or 40 minutes usually. PET scans are widely used as staging scans. They're scanned from basically the vertex of the skull to mid-thigh, and you get a whole hemibody PET uptake scan. They then also have a low-dose CT scan at the same time as that. And that's really for anatomical localization. If you just have the PET on its own, you just see blobs where there is uptake, and you can't really anatomically localize them. That's what the early scanners were like. So if you combine it with the CT, you get anatomical localization as well. So it's showing you anything in the body that takes up that tracer, and by far the most common one is this glucose molecule. There are lots of tissues which take up glucose normally, so obviously you have to be wary that other things do take up glucose. So for example, the brain takes up lots of glucose. So you can see people who've had significant strokes. If someone's had a big ischemic stroke, there'll be a whole area of the brain not taking up glucose. But basically PET with glucose is no use for brain because everything, it all takes it up. Heart takes up glucose and it gets excreted through the urinary tract. But then there are other areas like lymphoid tissue which takes up low levels. So they have to be interpreted with quite a lot of care because there's normal physiological uptake, and there's also anything that's inflammatory is going to be an active area taking up glucose. So it won't just show malignancy, it'll show lots of other things too. So that's one of the difficulties with PET scans. So PETs this is, it looks like one of these pictures you get of the night lights or something. It's actually the number of PET scans in America. So you can see they've got enormous number of PET scanners in America. So there's huge investment, and they'll charge nice large tariffs for this. So not surprising, people have started doing more and more PET scans in oncology. So this shows you the number of CT images on the left, and then the increase in PET scans. So this is old data, it's up to 2008, and it'll be continuing to go up. But PET scans are very widely used in oncology now. And of course, that leads people to think, what use are they? What are the specific indications, and where can they be most sensibly applied? one of those areas, there's a really big sort of research industry now in terms of PET for radiotherapy planning. So this was, I just put this into PubMed this week to see what came up. This is like I've just copy and pasted bits of the first page, but you can see that if you look at the tumour sites on this, people are looking at all sorts of tumour sites where the PET can be used for radiotherapy planning. And this is for the reason I was talking about, really, that we know CT is quite limited for contouring a tumour. CT often isn't what we use diagnostically, and often you can't even see a tumour on CT. Like for head and neck cancers, I treat head and neck cancer, we treat oropharynx cancers, and we know CT is probably the worst imaging modality to see an oropharynx cancer on. You often have dental amalgam and lots of artefacts, you just can't see it. There's very little soft tissue contrast on a CT scan. So of all the imaging modalities, it's probably the most limited. There's huge interest in looking at other imaging modalities. So on this, there's people are publishing for stereotactic treatment of oligometastases, brain tumours, endometrial cancer, chest, lung tumours, head and neck cancers, esophagus, another one on brain. So every tumour site you can think of, people are now looking at whether you can integrate PET for radiotherapy planning, essentially. So this is kind of the clinical role of PET, the potential places you might use PET in a patient pathway. So one is staging of the disease. So patients with various cancers get full body scans or bits of the body scan to look if they've got distant metastases. There's no point treating people with definitive radiotherapy if they've got distant metastases. For many cancers, PET is the most sensitive way of detecting distant metastases. For example, lung cancer, esophagus cancers will routinely have a staging PET scan. There's nothing to do with radiotherapy. There's interest in PET in terms of whether it's a biomarker, whether it has prognostic significance. Or even if it's a predictive marker. So a prognostic marker will give you information on what the likely outcome for the patient is. A predictive marker will, if you have got a true predictive marker, it'll tell you how a patient would likely to do with a particular treatment. It might guide your treatment choice. Rather than just telling your patient's got a good outlook or a bad outlook, it'll say they've got a good outlook with this treatment or a bad outlook with this treatment. It's not proven, certainly not proven as a predictive marker. In some tumour sites, there's evidence PET scans can be a prognostic marker. It doesn't particularly relate to radiotherapy planning. In terms of radiotherapy planning, you might think of using PET to choose your target. We spend quite a lot of time working out what to treat, so that'll be choosing which areas to treat, particularly in terms of lymph nodes. I mentioned about contouring. You might use PET particularly to try and contour the tumour, so for edge delineation of the tumour. And then there's a whole other very interesting area of adaptive radiotherapy and individualising treatment. So we know as patients go through radiotherapy, tumours change. Some tumours, when you see them in clinic partway through radiotherapy, people with big head and neck cancers, sometimes the lymph node really hasn't changed at all halfway through treatment. Other patients, within 2 weeks of treatment, it's regressed very substantially. That could be indicate their prognosis. You might think a rapidly responding tumour will do better. It might do, and it might be predictive. You might be able to then adjust your treatment. You might be able to say, this tumour is not responding well, I'd like to escalate dose or add in chemotherapy or change to a completely different treatment modality. So there's interest in using PET on treatment to work out how the treatment's going, whether that might have prognostic or predictive significance again. When you come to the end of treatment, PET can be used for response assessment. In Leeds, we do a lot of PET scans to do response assessment for head and neck cancers. And the reason is when you come to the end of treatment, you'll wait a period of time to allow cancer responses, but you can be left with residual masses. And you don't know if there's active disease in them or whether it's just sort of fibrosis or whatever. And PET can show you whether there's any actual functional activity in that. So rather than just saying there's something left, it might have cancer in, we better do an operation, you can look and see if there's any actual activity in it. So certainly for head and neck cancers, people used to do neck dissection. So head and neck cancers are quite prone to spread to lymph nodes in the neck. We treat them with radiotherapy or chemoradiotherapy, and then we assess to see if the lymph nodes have disappeared afterwards. Previously, or certainly sometimes you might do a CT or an MRI scan, you can see the lymph node has gone down, but there's still significant lymph node tissue left. And you've just no idea whether that's got disease in or not. You can do a neck dissection, remove all the lymph gland tissue, and you see cancer cells in it, but you don't know if those cancer cells are viable. They can just be non-viable, dying cancer cells. So there's a potential role for things like PET to show if there's any functional activity in it, if there's any sort of metabolic activity. Are these cancer cells actually alive and using glucose? And there's a big literature in various cancer sites of using PET for response assessment after radiotherapy. And then at the end of the process, a bit like the beginning, PET's very good for staging. It's very good for recurrence detection for many cancers as well. Like if you're suspicious of recurrence, that might be a role for PET. So in terms of radiotherapy, I was going to talk a little bit about target selection, about how you might use PET to choose what to treat, and then about contouring, how you might use PET to actually define the edge of the tumour, which is what we spend a lot of time doing without PET. And then much more of a research area of treatment individualisation. Those are the bits that kind of directly relate to the radiotherapy planning process. And I suspect in the next 10 years, PET's going to be increasingly integrated into these pathways. That things are not going to be continue to be based on CT alone, or even MR, I think. So this is a section on target selection. So this is not about exactly where you draw your tumour, your gross tumour volume, but more about which bits you decide are your gross tumour volume. And PET can potentially be useful here. So this is a head and neck cancer patient. So on the left is the CT component of a PET scan, and on the right is purely the PET component. So you can see if you just have the scan on the right, which is just the PET part, it's not tremendously useful. It's hard to get much anatomy from that. You can't really see what the structures are, but they're done at the same scan sitting, so the radiographers will acquire the PET and the CT at the same sitting. So as long as the patient doesn't move, they're inherently co-registered. Sometimes you do see a slight mismatch between where the PET signal is and the CT signal. Presumably the patient's moved slightly because it is quite a long scan. Scans are often 30 or 40 minutes. But they should inherently be co-registered with each other. So this is a patient, there's a big primary tumour there and a lymph node here. And there's a sort of suspicious lymph node there. It's difficult to know if it's involved or not, and it does show up on the PET scan. So the PET scan's giving us a bit more information about the tumour. It doesn't say that lymph node has cancer in there, because you can have reactive lymph nodes. If you've got infections or inflammation, a lymph node will be reactive, and it shows up a bit on a PET scan. But certainly sometimes PET clearly changes what we do. This was a patient we treated with a maxillary sinus tumour. We don't normally treat lymph nodes with maxillary sinus tumours, and in the arrow, there's a very clear retropharyngeal lymph node that hadn't been identified on either CT or MR. So we modified the radiotherapy to encompass that. So PET certainly changes the target volume on occasion like that. One of the big areas PET's used for is lymphoma. PET's probably been integrated into lymphoma pathways far more than any other. And there's a lot of interest in trying to develop PET-based planning for lymphoma. Lymphomas are quite tricky in that sense, because they're often treated with chemotherapy first, and then they have radiotherapy after the chemotherapy. They respond very well to chemotherapy, so you're left with very little to see on your planning CT scan at the end of chemotherapy. So what you're supposed to do is treat the pre-chemotherapy extent of disease, which is quite challenging, because the patient position for a PET scan is with their arms up generally. Certainly for lymphomas, is with their arms above their head, and we might treat them in a very different position. So trying to reconstruct where the disease was before chemotherapy is difficult. So there's certainly an interest in trying to perform the diagnostic PET at the beginning in a treatment position, so you can then use it to plan the radiotherapy. But PET makes quite a big difference to what we choose to treat in terms of target selection. So this is a series from a few years ago. And they looked at what the target was if you purely planned based on CT, and then when you use the PET scan. And there was 36% of patients, they had PET avid lymph nodes, which would have had lymphoma in. They were not identified on the CT, so they changed their target volume quite substantially by using the PET information. That's not to say you can only use PET. So this is the same work essentially. If you look at the scans, the bits lighting up are the PET signal. But there are big masses here. There's You can see there's a huge, big mass, but very little of it is lighting up. Now that's all lymphoma, but very little of the mass actually takes up the signal. So you can't just use the functional bit, you do need to use the anatomical image as well. So you need your anatomical imaging with CT. And then the PET shows you other areas potentially beyond what you would have identified purely on CT. This is a patient that came through the head and neck MDT a little while ago. So this is a T2N2B squamous cancer of the tonsil on the left. And you can see on the left there's a kind of a white area with a mat of lymph nodes up there, that sort of big lymph node area there. It makes a big difference, as you know, when we treat with IMRT, which lymph nodes are involved. We'll give them a high dose and we'll give prophylactic doses to uninvolved lymph nodes. And that makes a big difference to toxicity. So this patient, there was a key issue of, is that lymph node arrowed on the other side involved or not? If that lymph node's involved, we'll give say a 70 gray dose to the other side. If it's not involved, we give a prophylactic 50 gray equivalent dose, and that makes a big difference to toxicity. So the MDT said, well, let's use a PET to try and work out whether that lymph node is involved or not. Now, I've told you PET is a bit limited in that it will show up cancers, but it will also show up reactive lymph nodes. And it showed a degree of uptake in that lymph node. So SUV is the kind of a measure of the maximum uptake on a PET scan. SUV3 is a little bit of uptake. So it showed a little bit of uptake, and it leaves you none the wiser. It's not a very good way to use PET. That PET isn't very good as a standalone modality for identifying whether cancer's in that lymph node. So you do have to be a bit careful with PET. It's not an answer for all things in terms of where you treat. This is a study with pathological correlation, kind of looking at that question. So was the MDT right to say to use a PET? This is a study where they had a whole series of patients who'd had CT, PET, and ultrasound-guided fine needle aspirates. And you can see in terms of the results, I've just highlighted the overstaging bit, there's not much difference between PET and CT. Ultrasound FNA looks like the best. In terms of the negative predictive values, that's if you've got a negative scan, how likely is that to be correct? And PET's really not terribly good. It's only 50% in this series. So PET isn't very good in that sense. It's not a diagnostic test you can use to say that lymph node's involved or not for head and neck cancers. And it varies a bit with tumour sites. So some tumour sites PET performs much better, in the lung, for example. Other tumour sites it's not terribly good. So you do have to be careful with PET. It's not going to completely, you can't just say, I'll only draw when I contour bits that are PET avid. And that's not PET avid, I don't need to worry about it. Another thing you get with PET, I mentioned PET obviously only is relevant when there's if there's perfusion, so that you can get necrotic lymph nodes. There's no perfusion of the necrotic bit, so of course they're not going to take up the tracer. So there's a big lymph node there, which is arrowed on the CT bit, and on the PET scan it doesn't take up the tracer, and simply it's a necrotic area. It's still disease, but it's not taking up the tracer. So PET has a role in target selection. Certainly in lymphoma it does. Some other tumour sites it can identify areas you've not detected. But you have to use it with caution. It's not a test to use just on its own. You need to integrate sort of clinical examination, other types of scanning, perhaps biopsies of equivocal areas. So there's a role for PET in target selection. It's not the answer to everything. This is probably the sort of area where a lot of research is going on in terms of PET, of how to contour a tumour. So this is actually when we sit in our planning room and draw the edge of the tumour. This is this week's edition of Clinical Oncology, and this is a London group publishing their efforts to work out whether you can use PET for esophagus cancers. They come up with a kind of typical conclusion you get from these little planning series where you've got the PET target volume was bigger than the CT target volume in some patients and smaller in some cases. So PET is different. You'll get a different answer. You'll draw a different thing with PET. You don't know which is better. There's no pathological correlation. You don't know, is the PET tumour better or is the CT tumour better? So if we use PET, there are a whole series of issues you have to overcome. It's definitely not easy to use a PET for planning. One is we're still going to plan on the CT. You need the planning CT for electron density and the accurate geometry and anatomy of the patient. So if you're going to use PET, you've got to have that registered. So one way is to do a planning PET CT. So there are CT scanners which have a PET encompassed within them with laser light alignment and a radiotherapy couch top. So essentially it's like having a planning CT, but there's an integrated PET. So that's the ideal world if you're going to use PET. You can place the patient in their immobilisation devices, and it should be very much the same as a planning scan, albeit with a longer scan time. If you don't have that, and you've got a diagnostic PET, you might try and do the diagnostic PET in a treatment type position, and you can rigidly co-register it to the planning scan. They're not going to be in identical position, the patient, so there are going to be errors in that. There's another technology of deformable image registration where you might try and deform the image onto the planning scan. There are issues with that, but it's a kind of potentially very good evolving technology to try and use diagnostic imaging more. If you have got a way you can confidently, accurately co-register the PET scan or do it in the planning position, then you've got to work out how to define the tumour. So this is where is the edge of the tumour that you can see on the PET scan. Now PET's a very nice qualitative imaging technique. So when a nuclear medicine radiologist looks at a PET, it's qualitative. There's a nice blob that looks like tumour, there's a bit that doesn't look like tumour. They're not particularly good, and what they don't generally do is where's the edge of the tumour. So can we turn it into a quantitative imaging modality to plan? So those are two big issues with PET really. PET it's quite a different type of scan to a normal CT or MRI scan. There's image noise, there's partial volume effects. A PET voxel is quite big, so the clinical PET scanners, one single voxel is about 4 or 5 millimetres in size. That's a lot bigger than we normally think about in terms of radiotherapy, errors, etc. And there are reconstructions uncertainties too. So all of those things have to be considered if you're going to use a PET. And nevertheless, PET is, we know, I showed you at the beginning, on CT we're hugely variable where we draw the tumour. So PET might well be able to help that, despite those uncertainties and problems with voxel size. You can see there were bigger than 5 millimetre differences in where clinicians were drawing tumours on the CT. So this is a PET. So if I got you all to draw this PET, where the tumour is, I suspect you'd all draw something fairly similar. You'd probably be fairly confident you knew where that tumour was. If I change the window settings of the PET, the tumour's rapidly progressed. And I change it again, the tumour's rapidly progressed again. So PET, if you just look at a PET, it's actually very difficult just looking at a PET to say where the tumour is. You'd be quite happy on that, but then you'd look at that and think, oh gosh, I may have got that completely wrong. And that's simply, you change the window settings when you look at it on the imaging screen. And you don't know which the best window settings are. So it's very hard to visually contour a PET, just to say that's the edge of the tumour. Some people do advocate just doing it visually, on the basis there isn't anything better. If you're going to do that, you have to have very strict windowing protocols and things. There's a whole massive physicsy area of how to do it in an automated fashion. There are certainly some people who say there's no way you should do it manually because you don't know what you're doing and you have to use a computer algorithm to contour a PET. You can just take a percentage of the maximum uptake as an edge of the PET scan. You can do sort of signal to background ratios. There are various gradient-based methods. So it's kind of called different segmentation methods. It's trying to work out where the edge of the tumour is on PET. There's absolutely loads of these methodologies, most in-house that are not commercially available. There was a term coined of yapetism, which is yet another PET segmentation algorithm, because there are so many. This led to this exciting championship. This was, I think, one of the same years as the World Cup. This was the PET championship of the world to contour. So they had various funny shaped phantoms, not spheres, but kind of worm shaped phantoms and all sorts of weird shaped phantoms. And then they had some clinical cases as well. And they got all these companies and institutions to come along with their favourite PET algorithms to contour it. And then these were the kind of results. And basically, there's no one winner. The best on the phantom wasn't necessarily the best on the patient, and vice versa. But that just shows you how many different ways there are. This is a mixture of very manual versions where I'd look at it and say that's where the tumour is, to some very fancy automated versions. You can see PET might make a difference. This is a methionine PET. So this is looking at protein synthesis on the left in a glioma patient. And it's quite different. You can see where the tumour looks like it is on the MRI and the CT scan. You're getting a very different answer from methionine PET. So although there are difficulties, don't dismiss it because it could make a very big difference. The other thing is we can look more at multimodality imaging, looking at CT, MR and PET scans together. You can use these co-registration technologies to integrate all of this into one process. And it might be we shouldn't just be relying on one imaging modality. We should try and use all of the best diagnostic imaging modalities. There's very little in the literature of actually correlation with histology. There are 2 series like this in head and neck, and I don't think there's much in any other tumour side. And these are quite interesting. So these are larynx hyperpharynx patients. These are patients who then went on to have surgery. So you've actually got the larynx in a pot afterwards to see how big the tumour actually was. So these were 10 patients. The average volume of the tumour when it was drawn on CT was 13 cubic centimetres. When it was drawn on MR, it was 18 cubic centimetres. When it was drawn on PET, it was 10. So they're quite different. The pathological tumour volume was only 7. So the pathological tumour was actually a lot smaller than it is on any of these imaging modalities. But quite concerningly, none of these imaging modalities completely covered the pathological tumour. So even though the actual pathological tumour was quite small, it was not completely covered by any of the 3 imaging modalities. Probably in the head and neck region, that's due to kind of mucosal spread, just thin layers of disease going up the mucosa you're just missing on imaging. But it kind of suggests that we have a lot of confidence in drawing our tumours on CT or MR or whatever, but actually we're not necessarily very good at covering where the tumour actually is. And there's another series of almost identical results to this, so it's quite a reproducible finding. This is a little study we're doing in Leeds of looking at this. This is a series of patients who had a planning CT PET, so it was an integrated PET CT in a mask, and they had a MRI scan in the mask, and they've been co-registered. And we've had various clinicians drawing tumours, and you can see we've got very different results. We've got what the PET volume is in blue, the green is the CT, the orange is the MR, and they're very different. It's quite perturbing. Now we're treating patients, we'll define our high-dose CTV by maybe that GTV plus a centimetre. That's going to be hugely different depending on which imaging we've used. So you might look to use all of those together, and Memorial Sloan Kettering published their kind of experience of using all imaging modalities together. And they certainly found, as you added imaging modalities, the GTV got bigger. So the CT and PET was different to the CT combined with the MR, for example. And they also highlighted, a bit like the pathological study, that you need clinical examination as well, because that's going to add to where you think the tumour is. So that was kind of about target delineation. So it sounds lovely to use a PET for target delineation. There's a lot of problems about where you define the edge of the PET scan, which imaging modality to use. Do you use multimodality imaging? I think that's the way things are going to move in the future, is people are going to look at multimodality imaging techniques. Some people are looking at PET-only planning and studies in Europe. I suspect probably people will want to use multimodality imaging, a bit like that sort of American series. Some tumours move. So obviously chest tumours, esophagus, lung cancers move. So we're not going to be very interested in a static PET CT for that. People have probably one of the sites people are most looking to integrate PET is in lung cancers. And people will often use a 4D simulation CT scan to plan lung cancers. So can you do a 4D PET CT scan? You can do. This is a 4D PET CT scan. So this has got a 4D CT scan, and it's also got the 4D PET integrated in it. So there's certainly, this is an esophagus cancer. So this will give you an individualised attempt to work out how much the tumour is going to move with respiration in this patient. So it might be, we think we're doing nice things with 4D CT. It might be in the future we can start doing 4D PET scans. This is a lung cancer patient, very much the same, if it moves. Yes, it does move. It's breathing. So it moves up and down with breathing. So it would be a very nice way to integrate PET into 4D as well. So not just for head and neck cancers or pelvic cancers, but for maybe for the chest tumours where you've got respiration as well. I said I'd talk a little bit about treatment adaptation and what happens during treatment. So tumours change during treatment. A tumour might respond poorly. We might want to escalate dose. We might want to add in chemotherapy. We might want to switch to surgery. Perhaps more likely, tumours might respond very well during treatment. We might actually want to stop the radiotherapy early because we've already done the job and we don't need to put them through the extra toxicity. So there's a lot of interest in, can we use scanning during treatment? There's a whole range of targets you might look at. So these are different PET tracers. At the top I've put FDG, which is the glucose. You can look at accelerated repopulation with FLT PET, looking at DNA synthesis. You can do hypoxic traces. You can look at protein synthesis. I showed you the methionine PET in the brain patient. You can look at apoptosis. So you can think of imaging actually the biological processes in a cancer to look how well it's responding to treatment. You can start imaging some of the 5 R's of radiotherapy. You can start looking for repopulation, for hypoxia and all those sorts of things. And you might look at subvolumes. This is a functional subvolume of prostate cancer. People have looked at trying to dose escalate just to this functional subvolume. This is a hypoxic scan. So on the top is the normal FDG PET looking at glucose uptake. We know hypoxia conveys radioresistance. So you might think, if I can identify a hypoxic bit, I'll give a higher dose to that. And the scan on the bottom is a copper ATSM PET. And you might think of giving escalated dose to a hypoxic area. This is an example of planning to a hypoxic PET. The normal PET on the top with glucose is showing general metabolic activity. There's a primary cancer and lymph nodes either side. On the bottom, there's a hypoxic area. So we might have very individualized radiotherapy, dose escalating to a hypoxic area. That's a very attractive thing to do. We think patients fail radiotherapy due to hypoxia. We might be able to do something about it. There is a problem, though, that you have to remember tumours is a dynamic. They're going to change. They're clearly going to change during radiotherapy. Hypoxia consists of acute hypoxia and chronic hypoxia. That's going to vary too. So this is an example of a hypoxia PET scan. So on the left at the bottom is the normal glucose metabolic activity. On the right are 2 F-meso or hypoxia tracer PET scans. And they're quite different. They were just repeated a few days apart. And you're getting, with that particular tracer, you're getting different results. So you'd be very nervous of planning radiotherapy based on that hypoxia PET. Because depending on which day you do it, it looks quite different. There are other tracers which perhaps are more consistent now. So it's very much a research area. But you have to remember, if you're talking about a PET voxel, if you're going to start trying to think you're imaging the biological processes within a PET scan, the PET voxel is about 4 or 5 millimeters. But if you look microscopically at a PET, this box is the size of a PET voxel. Within that, the red's a proliferative marker and the green's a hypoxic marker. And they're intermingled. You've got proliferative changes mixed up with hypoxic changes. Tumours are not just divided into a hypoxic zone and a proliferative zone. It's a very complex biological process. So a big PET voxel kind of muddies that, I think. It blurs that process out. So you have to be a bit careful of what you think you're actually doing with PET. In terms of, I've talked about how you contour a PET, about how you look for edge. That's contouring by one method. There's another method which certainly the sort of Dutch and Belgian centres are quite interested in, dose painting by numbers. So rather than saying this is the edge of the tumour, they do it rather more mathematically and just simply say these are the voxel intensities and plan to each voxel intensity. So it's called dose painting, trying to give different doses to areas of different voxel intensities. Rather than saying that's the edge of the tumour, just dose painting to different intensities across the PET scan. It's very much a research area. You have to question a bit how much what the PET is showing you truly represents tumour biology if you're going to do that. And is it reproducible? If you do the PET a different day, is it going to be the same or is it going to change during radiotherapy? We certainly know tumours change during radiotherapy. Head and neck cancer shrink during radiotherapy. We could adapt treatment to that. This is an example of a study we've done of a PET scan of FDG PET during treatment. So this is a head and neck cancer patient with a big tumour at the beginning. It's I think, a follicular tumour, so the oropharynx tumour. So after 11 fractions, the tumour's shrinking. After 21 fractions, it's really responding very nicely. This is a patient you'd be pretty optimistic about. The tumour seems to respond very well. That's quite a powerful potential indicator of what's happening during treatment. This was a study looking at exactly that, doing a PET CT scan with FDG about 2 weeks into treatment. Patients who had a big change or big reduction in the PET uptake after 2 weeks at the top of that Kaplan-Meier curve, doing very nicely. Patients who had a disappointing change in the PET do quite poorly. So it's quite strongly prognostic. There's another almost identical study, except this time using FLT PET, which is looking at proliferation, one of the things we're interested in radioresistance. If you've again, a proliferative FLT PET can stratify patients on treatment, 2 weeks into treatment, into whether they're going to do well or badly. So we potentially can scan a patient 2 weeks into radiotherapy and say, this is going great, very good chance of cure. Let's consider what you might do. You might be able to do a trial to de-escalate the dose in that circumstance. Or you might take the group doing badly and say, this isn't going badly, we need to try and do something a bit more. And you might do a trial in that sense. This is again from the study we did. This is looking at various imaging modalities. This is just to say PET isn't the only imaging modality. There is MR, there are functional MR sequences, diffusion weighted, DCE, MR, and they all change. So on the right is the PET scan, again reducing nicely during radiotherapy. There's changes on CT, on MR, on functional MR. So when we analyse this is just graphically showing you the percentage change in each of those quantitative imaging modalities, or the size of the tumour on CT or MR. And they're all changing. It's not just PET that's changing. Every imaging modality can detect tumour changes. Which of those imaging modalities is best, which is most strongly prognostic, or which might be a predictive biomarker letting you change treatment, I don't know. But there's a whole sort of big area you might be able to intelligently integrate a whole series of different imaging modalities into treatment with either anatomical imaging or functional imaging. And this just shows you, I've talked about glucose metabolism mainly at the top with FDG PET, but these are all biological processes we can image, some of them with PET tracers, some of them with MR sequences, some with CT. There's CT perfusion, you can look at blood flow in a tumour. So we can start to look at apoptosis, hypoxia, angiogenesis, membrane synthesis, various metabolism, that's MR spectroscopy, proliferation. You can imagine all of these could provide you very interesting information about what's happening to a patient during radiotherapy. Either prognostically before treatment, prognostically during it, or predictively. You start to be able to potentially image the actual processes of a radiation response or mechanisms of radio resistance. So you can come up with a much more individualised approach to treatment, rather than just saying, I'm going to treat all my head and neck cancers with 70 Gray with a GTV plus a centimetre. You can say, I've got all these biomarkers before, I'm going to image them during treatment, I might be able to adjust my treatment to how they're doing. I know this is a hypoxic tumour, I'm going to do this, I'll add a radiosensitizer, or this is a highly proliferative tumour, I'll add in chemotherapy, etc. You might be able to come up with something much more individualised. That's probably where the future, I suspect, holds, but it's quite difficult to produce clinical trials which tell you whether that makes a difference. Like all radiotherapy, most of it's just small incremental technological advances without really clinical trial evidence to back it up. It's not easy to design clinical trials that really validate these biomarkers, but there's certainly possibilities of adding in imaging into sort of almost as parallel studies into ongoing trials to look at their potential. There's a head and neck study at the moment called NIMRAD, which is looking at nimorazole. So nimorazole is used as a radiosensitizer in the Hanka region, so Scandinavia essentially. All the head and neck cancer patients get nimorazole. Nowhere else in the world uses nimorazole. And they've got nice trial data that has a benefit. It's an anti-helminthic drug, so it's not particularly appealing. But there's a UK study now looking at it, and they're going to add in FLT PET as a parallel study looking at whether you can detect changes in what's happening alongside. So there's certainly questions you need to integrate into trials to see if these technologies actually are going to make a difference to patients. So basically it's very promising. I think PET's a very promising technology. It's a new technology. There's lots of questions about it. It's not straightforward. You can't just say, I'm going to start doing PET planning. You've got to think about how you might use the PET. Is it going to change your target selection? How are you going to co-register a PET, or are you going to do a planning PET CT scan with laser room alignment and things? And then how you contour the edge of the tumour. All of those are really interesting questions, and there's a big whole research area of tracking how a patient does during treatment. So thank you.